Hi guys, I'm Mona Canales. I am a nephrologist at the VA in UF, and I will be working with you on, I believe, Thursday of this week on kind of a practical activity in which we try to build a trial around a concept in nephrology that I'll briefly introduce now, but that we'll talk about more at that time, and that I've provided some links to readings for in the syllabus. But I have this talk here that I am narrating for you now to look over in advance of our session together, because I think it will kind of stimulate your thinking in preparation for that. And I'll review some of these concepts again that day. But this talk is called In Pursuit of Truth, Building and Appraising a Valid Trial. And this talk is originally designed to sort of be a source for how to appraise a randomized trial, but I worked backwards in kind of how you would build a trial. So you would think about all the threats to bias or threats to the truth as you structure a trial and how we overcome that. And so I think this will be really helpful to you guys as you are doing the activity with me on Thursday. This is all trial and error. This is the first time I'm doing this with you guys, so we'll all learn together. So let's get started. The objectives of this narrated presentation is that I want to highlight some resources to help you appraise the literature. I want to go over briefly the hierarchy of basic clinical study design. I want to define the principles underlying the proper design of intervention studies, and then outline kind of a structured approach to critically appraise a randomized trial that you can then take and apply to, if you were to build a trial, how you would make sure you had those elements there. All right, so let's start with a case that sets the stage for the nephrologic issue we're going to be dealing with, and will be the segue to building our trial. So this is a gentleman who presents to your office for routine follow-up for uric acid stone disease. He passed his first stone 10 years ago and has passed several more in the interim. His stone analysis is 100% uric acid. He's been asymptomatic from a kidney stone standpoint. He's been prescribed potassium citrate to treat his uric acid stones, but he says it upsets his stomach and he frequently misses doses. This is a common complaint with use of potassium citrate. His past medical history is significant for obesity, diabetes, hypertension, and gout. He's on the potassium citrate plus lisinopril for blood pressure, Lasix as well, insulin, and allopurinol. On exam, he appears euvolemic. His blood pressure is 135/75. His laboratory data is pertinent for normal kidney function, and his urine pH is very low at 5.1. Urine pH of 6 is what we call neutral. Anything above that is alkaline, and below that is acidic. You encourage him to take his potassium citrate, and you prescribe a powder form that he can put in his favorite drink, hopefully to encourage adherence. Before he leaves the office, though, he stops and he asks you if there are any other alternatives to potassium citrate to treat his disease. So scratching your head and kind of thinking about the pathophysiology of uric stone disease, you think about this. So let's introduce uric acid stones, just a little bit about them. We'll talk more about them on Thursday in person, but uric acid stones are not the most common type of stone. Calcium-based stones account for about 80% of stones, but uric acid stones account for about 10% of stone formers. They're associated strongly with the presence of gout, diabetes, and this just general metabolic syndrome. And the most important thing to note here is that the primary driver of uric acid stone formation is a very low urine pH. These stones love acid urine. So here on the right, there's a picture of the urate crystals in the urine. And then here in the middle is the front cover of the Clinical Journal of the American Society of Nephrology with a picture of a kidney with a massive uric acid stone there in the pelvis. And in this case report, they were able to alkalinize the urine by giving a lot of potassium citrate. Citrate's like bicarbonate on steroids. And they basically dissolved this urine. So this is one of the few stones that we can actually dissolve with medical therapy. The problem being people don't usually tolerate potassium citrate. To demonstrate the impact of urine pH on risk of uric acid stones, This graph illustrates on the x-axis the total amount of uric acid concentration increasing as you move to the right. And on the y-axis is undissociated uric acid. So the higher this number, the more uric acid you have out of solution. And so this is sort of the line above which uric acid starts coming out of solution. So you don't want to be above this line here. And you can see here that the association between how much uric acid you have in the urine and how much comes out of solution is highly contingent on the urine pH. So if you look here, if you have very alkaline urine at 6.5, you can have a very high concentration of uric acid in the urine and still stay in solution. Crystals not coming out, so they can't stick together and form a stone. Conversely, if you look at very low urine pH, our patient's urine pH was 5.1, so just around here, that even at very low concentrations of uric acid, you are coming out of solution, forming crystals, nucleating stones, building stone. So uric acid stones are a low urine pH problem. But what drives that milieu that leads to uric acid stone formation, primarily that low urine pH, is complex. And until recently, or at least in common practice, the typical approach is to just simply alkalinize the urine without paying attention to the other factors that play a role. And indeed, there's a sort of a perfect storm of factors that are contributing to the development of uric acid nephrolithiasis. So you see here I have uric acid nephrolithiasis and then mixed calcium oxalate uric acid nephrolithiasis. There are folks who form a combination of those, but if you focus really here on uric acid nephrolithiasis, you can see here that obesity, as it leads to insulin resistance, diabetes, or diabetes on its own, impairs renal ammoniogenesis. And when you impair renal ammoniogenesis, you impair the ability of the urine to become alkaline. And so the urine pH is very, very low here. And this low urine pH leads to uric acid crystalluria, or coming out of solution, and uric acid stones. In concert with this, the obesity comes excess food intake, increased animal protein and purine intake, leads to increased urine titratable acids, which lowers urine pH. It leads to increased uric acid content, which contributes to uric acid crystalluria. And then obesity itself can cause a renal oxidative stress, some renal injury, even subclinically, which can create a nidus for crystal deposition, ultimately conspiring to cause uric acid nephrolithiasis. So it may be that a cocktail approach addressing a variety of these factors may be more beneficial. So a cocktail approach. So as we're thinking about this case and what we could do for this patient, there is a drug available that addresses both obesity, and through that insulin resistance, and the acid urine. This drug, called Cosimia, is FDA approved for weight loss. It is a combination drug. One component is phentermine, which is an amphetamine derivative that is a potent anorexic, and then topiramate, which is a proximal and distal carbonic anhydrase inhibitor that's typically used for migraines, but it also is found to be a potent anorexic. Many women who get on topiramate for migraines just don't want to get off of it because they have such great weight loss results. And on top of that, topiramate has a side effect in that because it's a carbonic anhydrase inhibitor, it alkalinizes the urine via bicarbonate dumping in the proximal tubules and distal acidification defects, leading to a high urine pH. So would this drug be beneficial for our patient, and how can we know? Well, in an ideal world, we would take our patient, we would give him the drug, follow him over time, and look at our outcome of interest. Perhaps uric acid stone disease, perhaps urine pH, we can talk about that. And then we would go back in time, and we would run that guy through every single thing he did just the same, except for the Cosimia. and look at outcomes. And we would compare the two. If Casemia is better, then we could say Casemia will be beneficial for this patient. Now, this is the counterfactual. It can't exist, obviously, but this is what we try to approach when we design randomized trials. So there's a hierarchy of evidence for therapeutic interventions based on how close you can get to this counterfactual. At the very bottom of this is just the anecdotal and of one kind of my experience with my patients. And there's basic science research, and above that are observational studies where you're looking retrospectively or prospectively without intervening. And then finally are the large randomized trials in which you perform an intervention and look at outcomes with various balancing and other strategies to minimize bias. And so if you look here at the spectrum of intervention studies, clinical study designs, observational studies here on the left may or may not have a time component, and they may be prospective or retrospective, but you are not doing anything to anyone. You're just sort of looking back in time. And so this has its limitations with respect to bias and other factors. What we're focusing on today is the top of that hierarchy, which are intervention studies, at which the top is the randomized controlled trial. So back to our case, he wants to know, is there something else we can do for him? Well, Casemia is not FDA approved for this indication, but can we try to find out? Can we plan a study in which we figure this out? So let's just sample a population that's similar to our patient, right? Because we want to be able to apply our results to our patient, and then give that sample Casemia and look at the outcome, right? And see how they do. Are we sure, though, that that observed outcome was due to the intervention and not just simply the natural course of disease, right? The cold that gets better with antibiotics, it was going to get better anyway. How do you know it was the antibiotic? So, all right, we'll do one better. We'll get a control group. We'll get one group and give them Casemia and look at the outcome. And we'll get another group that gets no intervention and look at the outcome. Now can we say that the outcome we observe with Casemia is the truth, right? Can we rely on this? Well, what if these groups differed in ways that were important for the outcome, right? Maybe the Casemia group was healthier, right? Maybe they took better care of themselves. So here we're talking about selection bias. So selection bias refers to differences in the treatment and control groups that are important for the outcome. So these treatment and control groups differ at baseline in ways that are relevant for your outcome. So if your outcome is a cardiovascular event, if one group has more hyperlipidemia and hypertension and diabetes, right, that introduces selection bias. So how can we overcome this? Well, one way is matching. Just say, hey, for every diabetic we put in group 1, we're going to put a diabetic in this one, right? We match on things that we think are important for our outcome. The limitation here is that it's hard sometimes to find a perfect match or within a certain range. You can't match for everything, and there are unmeasurable factors or factors we haven't even thought of that we can't match on. So a step better than matching may be randomization. So randomization is where you could just do a simple randomization or a coin toss. You randomize to this group or that, and that ultimately your hope is that both measured and unmeasured factors will happen to be balanced. In small studies, simple randomization can lead to imbalance. So here's an example. If we have a study with 10 people, we flip a coin. It might work out perfectly that we get 5 in each group, or we may end up imbalanced with 7 in one group and 3 in the other. So one step further is to do permuted block randomization, particularly for smaller studies. This allows us to maintain pretty good balance between groups. So you can set your block size and say, hey, I'm going to randomize in blocks of 2. So if I randomize this person to group A, this one's going to go to group B, right? If I randomize this one to group B, this one's going to go to group A. The bigger your block size, the bigger the random permutations you can have in the order in which you randomize, but still within each block, things are balanced, right? And then you can go further and you can do stratified block randomization where your randomization occurs within strata. This is if you want to ensure that you have adequate representation of certain groups. This can be proportionate where, like, let's say you start with this example, you have a population of college graduates and you want to kind of study what happens to them after college, and you want to randomize in proportion to the distribution of race or gender or age or majors. And so you would do proportionate sampling. Or let's say you wanted to have an even number of different races or different majors, then you would do disproportionate sampling when, even though there may be more, poli-sci majors than psychology majors, you get the same number from each. So now let's go back to our study. So we have our population, we get our samples, we randomize, all right? Now group 1, group 2, hopefully we're dealing with some of that selection bias, and we look at our outcomes. Now are we convinced that the difference in outcome in the intervention group is due only to the intervention and nothing else? The answer is no. There's still further threats to selection bias, something that can make the groups different at baseline. And that's allocation bias. And we overcome this through allocation concealment. So what happens is that when study staff go to randomize people, right, they may get an envelope, pull an envelope that says, okay, this is the next randomization. If they can tell what that next allocation is going to be, they may be looking at that patient and say, I don't think they're going to do that great with this intervention. I'm going to just put this back and pull out another one, kind of shunt them to this arm versus another. And this introduces bias. So good quality randomized controlled trials will do their best to conceal their allocation so that those who are in control of allocation are not aware of and can't control the arm to which a participant is allocated. The best way to do this is through remote randomization, where basically the staff have to call a centralized randomization center and they just assign the randomization. Another kind of way to conceal allocation is to have bigger block sizes. If you have a block size of 2 and you just randomize someone to A, you know the next one's going to be B. But if you have block sizes of 6, well, there are 20 different permutations. It's harder to predict. Indeed, a nice study was done that looked at several trials all in this kind of similar topic, and they basically identified whether allocation concealment was adequate for the study. It stated clearly whether it was unclear or whether it was inadequate. And you can see here that those studies in which allocation concealment was unclear or inadequate tended to magnify the treatment effect. So again, threat to bias. One final tool you have to deal with selection bias is basically to, once you've randomized, set up a table 1 where you look at all of the factors that you can measure that you think might be important for your outcome between the 2 treatment groups, and you compare them to see how similar they are. And if there's some imbalance in certain factors, you can take that into account in your analysis. It won't assure the balance of unmeasured or unconsidered factors, obviously, but the hope is that randomization will take care of that too. All right, so to summarize, when we think about reducing bias in our trial, minimizing the threat, to finding the truth, at the start of the trial, it's primarily selection bias. So treatment and control groups differ in important ways for the outcome, and we deal with that through randomization, allocation concealment, and through comparison of baseline characteristics. All right, so now let's go back to our trial. We're good now, right? We have randomized, we have concealed allocation, we've looked at our table 1, everything's looking good, we do our trial. Now are we convinced that the difference that we're seeing in the outcome is due to the intervention group alone and nothing else? Unfortunately, no. There are further biases that exist that can occur during the course of the trial that we need to be aware of to try to minimize. So these would be systematic differences between the groups in the care that's provided or an exposure to factors other than the intervention of interest that are important for the outcome. So this may be for participants related to knowledge that they're in the treatment arm. Maybe they've got a new lease on life now, they've got this new treatment, they're going to start exercising more, take care of themselves, and that could affect the outcome. The investigators, the research team, maybe the investigators are aware that this person is in the treatment arm, and so they may give more attention to follow up there, do differential measurement of data based on preconceived notions. The assessors of the outcome might be influenced by them just sort of having prejudgments about, whether the intervention should be efficacious or not. And then caregivers or co-intervention bias can also affect the validity of the trial, and that the folks who are taking care of the patient, the physician who's taking care of the patient, may be aware that they're in this trial and treat them differently because of that. So to deal with this, we do blinding or masking of anyone that we can. I don't like to use the terminology single, double, triple, because that's not as informative as telling me who is actually blinded. So if the participant's blinded, the study staff's blinded, the outcome adjudicators are blinded, that is way more informative to me. And then the use of a placebo is ideal in drug trials to be able to achieve blinding. And so here are some major groups that you might consider blinding: the patient, the clinician, the data collectors, the adjudicators of the outcome, and the data analysts, all for various reasons that could introduce bias. A word on allocation concealment versus blinding, because this confuses people, but they are distinct entities. So allocation concealment exists to prevent the study staff or even the participant from guessing which allocation is next, so they can't change it, right? This prevents selection bias, and it protects the randomization sequence before and until the interventions start. This can always be implemented, right? Even if you can't have a placebo, you have a surgical trial, someone gets surgery, someone doesn't, right? It's hard to blind that, but you can conceal the allocation so no one can predict what arm they're going to go to. Blinding, on the other hand, prevents guessing to which allocation the participant has already been assigned. It prevents performance bias or treating the participant differently throughout the course of the study, and it protects the randomization sequence after allocation, right? Because you've done all this nice work to randomize these participants to basically have a balance on measured and unmeasured factors, and you don't want anything to destroy that. Blinding, however, may not always be possible. Again, take the example of a surgery trial where you can't do a sham surgery on controls. All right, so again, to summarize, differences observed at the start of the study: a selection bias. Another source of bias or difference that arise as the study proceeds is performance bias, and you deal with this through blinding. Yes, so now we've done everything here. We've randomized, concealed allocation, we've looked at our table 1, everything's balanced, we've blinded everyone we can. And now, are there any reasons to question our results? Do we feel confident that the outcome we see related to cassimia is just due to cassimia and nothing else? So unfortunately, the answer is no. There are differences that can occur at the end of the trial that threaten the validity of the trial or our ability to count on it as a truth. And so loss to follow-up is one of these. If a loss to follow-up is large, including these individuals in the denominator, without any data on outcomes can bias results. So solutions to this is obviously rigorous follow-up of the participants, not always possible, but we do our best. And then you can do sensitivity analyses to exclude these participants and perform analyses with projected outcomes. Another difference that can occur at the end of the trial occurs when there's early discontinuation of a study due to a large effect, either harm or benefit. And this has been shown to exaggerate treatment effect consistently. And so here's sort of an example, a theoretical example of how this might happen. So here is this is time here, and so this is beneficial effect and harmful effect, and this is no effect. And let's just say for argument purposes, this is the true effect right here, okay? Early in the course of the trial, you have less data, maybe less people enrolled, less outcomes have occurred. And so because of that, your power is less and your point estimates are less stable. They tend to vary widely about the truth, right? And so you are at a much greater risk of having a very high treatment estimate early on that maybe crosses your boundary that you've set as, hey, we're going to stop. It looks like this is way beneficial or way harmful. We have to stop. And so you stop early and you think this is the treatment effect, but really the treatment effect, if you would have continued to follow everyone as you had planned, is not so exaggerated. And this was borne out in this kind of large meta-regression analysis and systematic review that was done, looking at a spectrum of trials across subjects, comparing trials within each given topic that were truncated versus not truncated. And what they found was that, in general, the point estimates favored a greater treatment effect for trials that were truncated, further corroborating kind of the theoretical picture that I just displayed for you. Okay, finally, the biggie is that some participants will complete the trial but will not receive the assigned treatment. Maybe they just didn't like it and they stopped it. Maybe they just forgot to take some, who knows what happened. How do you deal with this? You randomize someone to take Casimia, but they didn't take it for the whole trial. So you could A, reject the trial as a failure. So this wouldn't leave a lot of trials, money lost, probably not an option. You can just say, hey, I'm going to analyze people according to the protocol they received, which means that if you didn't get the treatment you were assigned, you're out. You're out of the denominator. You're not in the trial. So the problem with this, the fundamental problem with this, is that you constructed this trial so carefully at the beginning to minimize selection bias. You randomized, you balanced on measured factors and unmeasured factors, hopefully. And if you throw out people differentially in each group, you destroy that balance that you so carefully constructed. And this is why per protocol is in general not viewed as sort of the first line approach to this problem. You can also then, the converse would be to analyze people according to the arm in which they were randomized. This is called intention to treat, whether or not they received the drug. So you're in the Casimia arm, you didn't get the drug, you're still in the denominator, and your outcomes are in the numerator, and we're just going to go with it. The problem with this is that a lot of people find this hard to accept. It's like, wait a minute, you know, like, I want to see the effect of Casimia, but this person gets Casimia. But on the flip side, it maintains all the original balance that randomization gave you. It's also kind of a very pragmatic look at the sum totality of the path that people would take on this drug, because no use of any drug is perfect necessarily. There are oftentimes when patients start or stop a drug or miss some doses. So it's a very kind of pragmatic look at the effect of the intervention. Notably, it tends to bias the results toward a null finding. And in science, you will find we would rather have a null finding erroneously than erroneously have a positive finding or a finding of, benefit or harm, whatever we're powered to do. Most trials, in truth, present both the per protocol and the intention to treat for transparency's sake. If they're in line with each other, it's reassuring. So here's just a practical example of the effect of intention to treat versus per protocol analysis on point estimates. So this is a made-up trial of surgery plus aspirin versus aspirin alone in patients with cerebrovascular disease to prevent stroke. And so here we are, we have patients with cerebrovascular disease. They're randomized to aspirin at the bottom or surgery plus aspirin, and they're followed over a little over a year. And again, the assumption is that the truth is that there is no difference. So the relative risk reduction of the surgery plus aspirin compared to aspirin is 0, okay? And so that would mean that if there's 100 in each arm, there were 20 strokes in the aspirin arm and 20 strokes in the surgery arm. So in the surgery arm, what happened was 10 people had strokes before they could even get to surgery. So they're not going to get the surgery, right? So they didn't really get the treatment. In intention to treat says, hey, we still keep those in our denominator and numerator. So the point estimate is 20 over 100 or 0.20. And then for the aspirin arm, it is the same. So the relative risk reduction is 0. Okay. If we were to analyze this by per protocol analysis, we would say, hey, you guys didn't get the intervention here in the surgery arm. So you 10 that had the stroke are out. We're not going to include you in our denominator. We're not going to include you in our numerator. And so when we look then at the point estimate here, it's 0.11 for the per protocol, but 0.2 for the aspirin. And we look at the relative risk reduction, this minus this divided by this, it's 0.45, showing benefit for surgery. And this is just to illustrate how per protocol tends to be the less conservative measure. It tends to bias results toward a positive finding or bigger effect sizes, whereas intention to treat tends to bias toward the null. All right, so to summarize, reducing bias in intervention studies, threats to the truth, and these are things we're going to think about as we build our trial to make sure that we address these factors. Differences observed at the start of the study, that's selection bias. We deal with randomization, allocation concealment, table 1. Differences as the study proceeds, that's performance bias. We do that through blinding as much as we can. And then differences at the end of the study, loss to follow-up. We try to ensure complete follow-up. Stopping the study early due to large effects. Try to complete the study as initially planned and have very, very high bar for stopping. And then omitting patients who did not receive assigned treatment. And so that you would deal with this through intention to treat. So we're going to talk about these more when we meet to and build our trial of Casimia to potentially help our patient, right? And so we'll talk more about this on Thursday, but I just want to present to you briefly a tool that's available online to help you as you evaluate a randomized trial. Really, this is the CSP checklist. It's a set of 8 critical appraisal tools that you can use when critically appraising the literature, but you can also sort of work backward as you think about constructing a trial to think about the different components that are listed here. And they have these checklists for various types of studies, but we're going to focus on the criteria for evaluating trials. So 11 questions to help you make sense of a trial. So they're broken into 3 parts. 1, are the results of the trial valid? This is speaking to exactly what I've been talking about this entire talk, which is, are there any threats to truth in this study? In other words, can I rely on the results as truth? Section B talks about what are the results? How are you going to present the results, right? And then finally, will the results help locally? This refers to external validity. Like, okay, I've done this trial. I can believe the results. They have picked outcomes that are meaningful, and I can interpret the results, but does it apply to my patient, right? So, are the results of the trial valid? So there's a risk of bias. Did the trial address a clearly focused issue? So when you're generating your trial design, you're going to think about this. Your PICO, your population that you want to study. What's your intervention? What's your comparator? And what are the key outcomes you want to look at? Were they clearly stated? We will clearly state them as we develop our trial. Was the assignment of the patients to treatments randomized? How was this done? How will you want to plan it? Was there allocation concealment? At this point, you say, is it worth continuing? Then you ask yourself, were patients, health workers, study personnel blinded? So you need to understand exactly who was blinded. What did the table 1 look like? Did randomization work? Aside from the experimental intervention where the groups treated equally, a good study will have a protocol that will tell you exactly how many interactions the study participants had in the intervention group and the control group, how many times they met with study staff, what they had done. And then were all of the patients who entered the trial properly accounted for at its conclusion? So this is about stopping the trial early and about intention to treat versus per protocol. And you would in publishing the results of your trial, create this consort diagram. This is what you want to look for in trials, where they talk about who they assessed for eligibility, who they excluded from being eligible, who they randomized, and how many were lost to follow-up, and how many discontinued intervention, and who were ultimately in the analytic cohort. And your hope is that that includes everyone who was randomized, as far as intention to treat is concerned. The next section is what are the results? And so this is key in being able to digest a randomized trial and understand its utility. So what were the outcomes measured? Is the primary outcome clearly specified? We'll think about this as we design our trial, picking a key outcome we want to look at. And then what results were found for each outcome? Is there any evidence of selective reporting of outcomes? So they stated at the outset, this is what we're powered to do, but then they kind of cherry picked and presented the outcomes they felt were most exciting. How precise was the estimate of treatment effect? What are the confidence limits? Were they statistically significant? So here, just a word on point estimates, p-values, confidence intervals, and significance. So again, for the purpose of designing our trial, we're not going to dwell on this too much because we're not going to have results. But I want to put this in here because I think remembering this will make you a better reader of the literature. So remember, a p-value of less than 0.05 means something. It has an interpretation. It means that this result might have occurred due to chance on less than one occasion in 20. That's the interpretation of it, okay? So p-values are sort of on a continuum. This arbitrary threshold of 0.05 is something that statisticians have created, but you can interpret a point estimate with a p-value of 0.06 or 0.08, right? You can still look at the treatment estimate and then view that p-value as the likelihood that this result occurred by chance, right? Then the confidence interval. This is the spectrum within which the true difference between the treatments arise, or where the true point estimate arises. So if it's narrow, you feel really confident that the truth is really close to your actual point estimate. And then this is highly dependent on sample size, right? The bigger your sample size, the tighter your confidence interval. Remember that a statistically significant result may not be clinically significant, right? If you have a study that's huge and the sample size of 1 million, you're going to have a very tight confidence interval. You can be very, very confident about that point estimate and have a very low p-value. But if the effect is very small in magnitude, it may not be relevant, may not be clinically significant. So it's best to express your result in terms of likely benefit an individual could expect. So relative risk reduction, an absolute risk reduction, and then maybe a number needed to treat, which is 1 over the absolute risk reduction. How many patients you would need to treat in order to impact one patient with your intervention relative to your outcome. And then remember, at the end of the day, no one trial necessarily answers every question. You know, an association between two variables is more likely to be causal if it's strong, if it's consistent across studies, if it's specific to certain outcomes and interventions, if it's biologically plausible, and if there's a dose-response gradient. So finally, the question of external validity, and I think this is going to be really important as we design our trial. You want to design a trial where you pick a patient sample from a population that is reflective of the patients you treat and would want to apply the intervention to. Okay, so do you have reason to believe that your population of interest is different than that in the trial, right? So for us, we would want to design a trial that's similar to our patient, Mr. Z, right? Where all of the clinically important outcomes considered, right? Things that you would want to know for your patient population. And then are the benefits worth the harms and costs? And so I think this is important for us to consider in this trial. We'll talk about the cost of Kissimmee and whether or not, you know, the cost of that drug, which could be high, is worth the potential benefit. And so I'm going to end with these links to resources for you to use in the future. We can use them as we're generating the trial, but in the future, just as a physician, as someone who is a patron of the literature, to use as you assess trials. And then we will plan to meet on Thursday to talk more briefly about the topic of uric acid stone disease, but then to spend some practical time working together to generate and develop a trial to answer the question whether a drug, Kissimmee, could be used to treat uric acid stone disease. So to summarize, randomized placebo-controlled trial is the best tool we have to study the effect of an intervention on outcomes. Systematic error or bias can be minimized but not eliminated through various techniques. There are numerous resources out there to guide you guys to critically appraise the literature, and you can use these skills to design good trials. I look forward to meeting you guys on Thursday.